would like to introduce speakers, for an interesting topic is a debate on artificial oocyte activation and the Ionophore application. To begin with, we'll have the person to present for the evidence of clinical readiness, Professor Thomas Ebner from Austria. Professor Ebner graduated with honors from the Paris London University of Salzburg, Austria in 1992, and completing his doctorate and postdoctoral thesis, became a university professor in Graz. Has published more than 130 papers and book chapters. His research interests include non-invasive IVF selection process, andrology, vitrification, and cultural media. He's certified as a senior clinical embryologist 2008, and currently he is an EC board member of Alpha and head of the Embryological Forum Austria and national representative of Austria in the advisory committee of ESRA. Welcome, Professor Ebner.
Thank you very much, dear Chairman. Good morning, colleagues. I think it's time now to move a little bit from what I call basic science towards clinical application of methods. And I'm happy to start the debate, and obviously I'm an advocate of Ionophore application. That's why I have been chosen, I guess. First of all, I'd like to declare my conflict of interests. And amongst these relationships, actually only the latter one is of interest, because this is the company that produces a ready-to-use Ionophore. And although I do not have a financial interest, I have to admit that all the studies I do are with a ready-to-use compound. So I have no experience with other agents. The outline of my talk is a little bit of everything. I'd like to start with the principles of oocyte activation and move on towards the artificial oocyte activation. Then I'd like to talk on special indications that would actually sometimes require artificial activation. Then the next part of the talk would be on the mechanisms that could drive the calcium signal, which is not physiological, but actually somehow it works, and that's what I want to focus on. And last but not least, then talk on safety issues and on future aspects of such technologies. Oocyte activation is one of 6 major steps of in vivo and in vitro fertilization, which starts with the cumulus cell penetration and ends with the prenuclear formation. And this is a process entailing the release from phase 2 arrest and the completion of the second meiotic division, as well as the modification of the zona pellucida in order to prevent from polyspermia. There are certain candidates which are introduced theoretically by the sperm and then would artificially or physiologically activate the oocyte. And amongst these, the latter 2 are the most important ones and the most discussed ones. I do think that the phospholipase C zeta is the most studied one, and I've chosen a model to show you how it works. And actually, the sperm binds to the oolemma, and when it fuses, the membranes fuse, the sperm-bound phospholipase C zeta enters the oocyte and reacts with PIP2. And at the end, it creates 2 molecules, or 2 types of molecules. This is the D-acylglycerol, which is responsible for the zona reactions to stop other sperms to enter the oocyte in vivo. And the other molecule is the more important one in terms of oocyte activation, and this is the inositol triphosphate. This molecule binds to its receptors at the endoplasmatic reticulum, and in turn, calcium is released from the cell. So this is one way to get calcium higher in the cell. There are some others discussed, like the nicotinic acid, adenine dinucleotide phosphate, and ryanodine. And they also can release calcium from intercellular storages. The calcium that comes out of the endoplasmatic reticulum and goes into the cytosol, it presents in the form of oscillations. And these can be analyzed quantitatively. So you can count the spikes, you can measure the duration, the latency, the amplitude. And the area under the curve would actually reflect the amount of calcium that is available in the cell or that left the endoplasmatic reticulum, or in case of artificial activation, that came out from outside of the cell. Interestingly, the sperm induces mitochondrial respiratory activity, and the energy that comes from there goes back to the sperm, and that drives the signal through the cell. And like always, we have two extremes. On one hand, you have a normal fertilization that you can see on the left side, and this is the oscillation pattern of calcium in a fertilized oocyte, although it's a mouse oocyte. And on the right side, you have no effect at all. So there's either no calcium or it's not working properly. And whatever you do with the cell, either you freeze it, you vitrify it, you make in vitro maturation, it will change your calcium pattern. So not a single calcium pattern is the same. Even within a pool of oocytes, that's what I learned from the Belgium group of Björn Heinrichs, you have different patterns. And presenting oscillations of calcium is not there a priori. So it has to be acquired. So the oocyte, during the in vitro maturation or during the maturation, it has to get the competency to do that by either increasing the number of receptors of inositol triphosphate or changing the pattern of distribution, whether they are clusters or more distributed more homogeneously, makes a difference. Even the sensitivity changes within time. And of course, it's paralleled by different calcium storage amounts. Calcium oocyte activation, I told you that it stops, at least per definition, it stops once the pronuclei form, but calcium is, for every single mitotic division, is of importance. Immediately prior to every mitotic division, there's a little rise of calcium, and this rise you can't see if the embryo is arrested, either due to senescence or to apoptosis. If the embryo is not cleaving any longer, you have no calcium peaks, and you have no cell division. This is important for an indication I'm going to tell you later on. So I have shown you this picture, this missing of oscillations. And once you have a bad experience in a previous cycle, then you should take into consideration to change something. You can't do XE over again because you will end up with no fertilizations over the years. So there are a couple of techniques that would allow to artificially activate the oocyte. I don't say it's physiological, but at least there is activation of the oocyte. You could either choose modified ICSI techniques, or you can choose an approach that works with electrical activation, but most of us, or most of what has been published in literature, works with chemical activation. And there's a whole bunch of compounds that are there, that are available, that you can either mix yourself or you can get from commercial sources. But the interesting thing is that some of them give you a more physiological pattern. In other words, you will end up with oscillations, and others have only one single calcium peak, and then that's all. The problem with the physiological patterns is that they are a little bit less effective, and they're limited to some species. And there are reports of meiotic spindle disruption of them. So most of us are working with calcium ionophores, I would guess. And there you have two choices, either ionomycin or calcimycin. These are the indications of my lab. So we for every single study, we had an ethical application. So it went through the ethical forum, and we got the allowance to use this. We had informed consent for all of them. And of course, we started with the complete fertilization failure. So no fertilization after ICSI at all. And the next cycle, we did apply Ionophore, the ready-to-use Ionophore, because we are not allowed in our country to mix it ourselves, most probably due to European tissue directives. But I learned from Markus Montag from the University of Bonn, because they also used it if there is a low fertilization rate in the cycle before. So with less than 30%, this was their threshold, they applied ionophores. And so we did it in a prospective manner. And last but not least, we've chosen severe male factor, and we could publish it in Fertility and Sterility. Patients with crypto or azoospermia, non-obstructive azoospermia, to be more precise, and even in Cartagena syndrome, we had some success using ionophores. And last but not least, in the last paper from human reproduction, we had this in mind that mitosis goes together with calcium peaks. And if there is no calcium, we thought to support the cell with calcium. And then, yeah, we saw fascinating results, but we're not sure why we have seen them. But maybe that would be a good point to discuss afterwards. So, if I've mentioned before that ionophore, particularly calcimycin, gives you only one single peak, and then the calcium goes down, so why could it work? So this is a very important question. And we went through the literature, most of the basic science, and we found that the calcium calmodulin protein kinase 2 oscillates in parallel with the calcium signal, meaning this is a downstream event of the calcium pattern. And these colleagues have shown that in pathogenetical activation, as well as in the single and multitude ionophore usage, you have the same parallel situation. In other words, it indicates that artificial calcium recruitment can result in a proper downstream response, which might not be physiological, but at least it has a proper response. And secondly, the activity of this enzyme goes close together with the initial calcium recruitment. So with the first peak, the higher the first peak, the more enzymatic activity has been seen. And this is actually what we see if we use the ionophore, because we have only one peak. Another thing is that once you have no calcium left, that due to orthophosphorylation of this enzyme, it keeps the signal active. So you don't even need calcium once the signal is started. This would also explain why ionophores work. And last but not least, we have this paper from the Ghent group, and they say it's a matter of the area under the curve. So there is a certain threshold of calcium, and once you pass it, you may have a benefit, even if you have only one peak of calcium. So this brings us to the safety issues. And I'm pretty sure it's this inflationary use of ionophore techniques that led some colleagues to publish a warning comment, and we will hear it later on. And we, and our group and others, we answered to them. So there is an ongoing debate, and I do think this is very important because at the very end, we don't know whether it's ready for clinical application or not. Some things are alarming, some things are really reassuring. But one thing is for sure, we never said that this is physiological. So if you have a patient and you want to use ionophore, never do it the first cycle. The second thing is, if you do it, I would split the oocytes. If you have enough oocytes to split them, get informed consent of the patients. It's definitely not beneficial for all patients. So it might not work, and it doesn't work during our daily routine, and then you have to go even further with your ideas. Yes, and it's experimental, that's for sure. Jonathan Van Blerkum and Jacques Cohen, they published this comment in RBM Online, and they raised 4 very important questions. And I tried to answer the questions on the basis of our 5-year experience with this ready-to-use compound. So you see up to 9% of our patients have an Ionophore treatment, which is really a high figure. But you should not forget that we get patients from all over Europe to treat them with those techniques. Nevertheless, our figures are based on more than 300 cycles. So the live birth rate was 32%. So far, we have 126 children, some of them from vitrified blastocysts, so we're only vitrified blastocysts, and some of fresh. So the questions I've been confronted with is the miscarriage rate higher than would normally be expected? I would say no. So we had up to 20% miscarriage rate. And you should not forget, this is a very bad prognosis patient group. And I'm no clinician, I have no idea whether this is acceptable or not. Personally, I do not accept one single abortion, but of course, we have to face them every day. So if available for genetic analysis, are the products of conception eubrid or not? So far, within our 100 cases and within the group of published children, which are about, I would say, 200 to 300 altogether, there is not a single genetical disorder. So most probably genetic is not affected. And I will show you a paper from Italy later on, which would explain that at least in part. Do miscarriage rates occur at the same stage of gestation? I have no idea, but these are the data. So if the pregnancy stops, it's rather early. I don't know if this is what has been requested, but these are the data. And is the incidence of minor major congenital malformations within acceptable limits? So within the 126, we had only one major malformation from a vitrified blastocyst. So this is less than 1%, and this is what we see. And again, I'd like to draw your attention to the fact that this is a bad prognosis group. This is the paper from Italy. They worked with a 5 to 10-fold concentration of calcimicin, and they did not find a higher rate of chromosome segregation errors in Mayors 2. So obviously, or most probably, it's not changing genetics. In terms of gene expression, it could be shown that artificially activated oocytes, ICSI plus activation agent, did result in a comparable, at least more comparable to natural fertilization as compared to IVF. So there was not that much of a difference in terms of gene expression. Markus Montag published at one of the last Azure meetings that there is no difference in the timing of the cleavage events. So they annotated the morphokinetics of ionophore embryos and of control group. So there was no difference in these time points. Interestingly, the Belgian group followed their children up to the age of 10, and there were no difference in language skills, motor skills, cognition. So everything at first glance looks more or less normal. But as I told you, it's not always sure that it works. So if an ionophore treatment or any other treatment for artificial oocyte activation does not work, then you have to consider a new technique, which could be, at least according to literature, you could increase the exposure time. Although I could not find a paper that worked longer with a period longer than 30 minutes, you could switch to twofold exposure, that's what the Belgian group does. You could switch to a combination of ionosine and calcimicin, or you could choose a more invasive approach. But this would include the direct injection of calcium chloride within the cell, plus a double treatment with ionomycin. And last but not least, I think the future will be the usage of recombinant PLC-theta. The problem, however, is that the dosage is not defined yet, I would say. So my very last slide, I'd like to summarize that if I take everything that I found in literature and I published myself together, it seems that the human oocytes can respond to a wide range of intercellular calcium signal parameters. And they have a surprisingly high rate of tolerance for prolonged changes in cytosolic calcium. And so far, the neonatal outcome is promising, but yeah, It's definitely not physiological. So I would end up with the last sentence that artificial oocyte activation, particularly the Ionophore treatment, is in transition process from experimental to clinical. It still has to be considered experimental, but at least it gained some influence in the clinical experience of all of us. So thank you very much for your kind attention.